Hello, everybody. So today we're going to be talking about disordered eating in men and the implications to physical therapy. So here are some of our objectives. I guess I just really want you guys to understand the disordered eating. I want you to understand why men get them and how we can relate to physical therapy. I want you to recognize signs and symptoms, and I want you to be able to utilize the resources and the learning communication strategies to be able to talk to our patients who have these disordered eating issues. So now let's think about prevalence. So for the most part, we think that disordered eating and eating disorders have typically been a gendered psychiatric illness, most likely seen in females. A lot of the hallmark features in eating disorders were not viewed upon in males, obviously because men don't get amenorrhea, and men don't typically suffer from decreased bone density that females typically do suffer from. A lot of the research is spent on females, so less than 1% is actually done on males, and it makes us question, why is that so? Why do men not get enough research? Why is the research not as prevalent in the male population? Regardless of disordered eating, up to 60% of boys report that they actually manipulate their dietary practices to achieve greater muscularity. And that's within the context of gaining muscle or losing fat, right? They just want to just gain the muscle somehow, and they'll change their diet to do so. In a recent article, they saw that 22% of those who suffered from eating disorders or disordered eating are men. And that is without to say that we don't know if actually men are going to see their physicians for their eating disorders or their disordered eating. So really, take those numbers, not too highly. So then we think, why are these statistics so low? Why are these numbers so low? Think cultural bias for a second. Shame and alienation play a huge role in the eating disordered experience. For men, it's shameful to go to the doctor for these kind of things. It's shameful for men to think that they might have an eating disorder. And thus, if they feel like they're shameful to have an eating disorder, they will not go to the doctor to go get that addressed. A lot of the times we don't give the cultural awareness of men who have disordered eating or eating disorders as we do with women. And it's kind of like they have this need to look a certain way for society and for the sake of society. So it kind of makes us wonder, and it kind of helps answer the question why we don't have a lot of research on men who have eating disorders. Well, they just do not go to the doctor for their eating disorder. So something I kind of want you to think about is, do you think men who participate in physique competition suffer from any disordered eatings? Think about it for a second. So in the broad context of what's going on in our patients with disordered eating, in the umbrella, we call it muscularity-oriented disordered eating, which is the patterns that are associated with disordered eating in men who want to achieve a body image of some sort that has to do with their muscular image. They will go to the extremes to achieve this, like anorexia nervosa. They might have very disregarded feelings of how they feel with their muscles, like muscle dysmorphia. And a lot of this muscularity-oriented disordered eating can be either used to increase muscularity, which is in the form of bulking, or reducing body fat adiposity, which is cutting. So bulking versus cutting is kind of the two big things that we see in this community. So muscle dysmorphia, right? We think this is kind of defined as the dislike for their own body due to not having the ideal musculature. And so some signs that I really want you to think about and want you to see when you're in the clinic is, do they spend a lot of time thinking about their becoming muscular? Do they have excessive body monitoring? Are they dissatisfied with their appearance? And do they avoid situations involving their body exposure? These are some really key things and key signs to look out for in your patients who walk into your clinic. And it might not be as obvious. You really need to be able to delve deep into their subjective history and look for these signs. Anorexia nervosa. These are some other signs of anorexia nervosa, like they might have complete weight loss. They may wear multiple layers to hide their weight loss. They deny hunger. They have food rituals. They express the need to burn off calories taken in, and they may experience hair loss due to the inability to continue keeping in nutrition. So these are some really, really important aspects that you want to be able to see when you take in your subjective history of your patient. So think about, what's the difference between bulking and cutting, right? So cutting is a calorie deficit. You want to lose the fat and you're trying to cut the fat so that you can kind of increase your muscle and kind of increase the outlook of your muscle. Kind of like shaving off some fat so you can see your abs, right? So a lot of the people who do cut are dissatisfied with their bodies and they might have a really interesting cyclical dieting patterns to do so. Whereas on the other side, there's bulking, right? They may take in too much protein, too much calories to improve their muscle. And this is really rigid around consuming their protein, right? So it's like kind of two opposite spectrums. Cutting, you're very much limiting yourself, and it could be an extreme form of anorexia. And then bulking is like you're doing a little too much, and you might have these eating patterns that kind of look like disordered eating. So I looked into a research that looked at a longitudinal study of young adults over the US, and 1/5 of young men engaged in muscularity-oriented disordered eating. And we saw that there was predictors of this kind of disordered eating. We saw that they were male gender, obviously. They engaged in weightlifting or looked to gain weight. They were in their young adulthood ages of 21 to 40. They might have self-perceived themselves as underweight. They were either African American, and they participated in muscle building and team sports. So again, not particularly signs, but we saw that these were some predictors of those who delved into these disordered eating behaviors. So from a PT standpoint, what does this mean for us when someone walks in with these kind of predictors or behaviors, right? So now this begs the question, what do we do, right? We screen, and that is so important. Our light bulb should be up when we're taking our subjective history, when we feel like we need to refer, right? And this is screening through providing a questionnaire, listening to them during their subjective history. We want to be able to refer them. We want to warrant them based off their screen and send them to a specialist and or treatment center that would be appropriate for them, right? We want to educate on the risk factors of disordered eating and its implications on treatment. Food is fuel. We need these people to eat properly so that they can exercise in physical therapy for their injury. And a lot of the times we need to educate them that protein and food is so important for the tissue healing process of whatever injury they might be going through as well. We want to give them resources and let them know it's important that, we want to normalize using the resources, using websites, going to treatment centers. Most men don't, seek help for their eating disorders or their disordered eating, and it's truly because it's not normalized for them, and they feel like it's a shame, as I was mentioning earlier. So having those conversations about using their resources, going on the websites, and letting them know that they're not the only ones alone in their journey. And lastly, we want to treat them. So tailor our PT sessions to whatever kind of sport or physique competition, or whatever they're doing that's associated with their disordered eating. Of course, if they have not been eating as properly or if they've been not having the best habits, you might want to change your frequency, intensity, and the volume of exercise and also monitor vital signs because they might not be in the greatest physiological shape to tend to those exercises and the treatment and evaluation. So the next thing is we need to have these conversations. It is so important. Men do not voice their disordered eating habits, and it's a substantial lack of awareness of eating disorders in males to both the primary care physician and their patient. Instead of bringing up their problems of eating disorders, they simply mention personal routines on binging and purging. And so a lot of the time when you think about this, they are not looking at their disordered eating as a problem. They see it as kind of something that they do on top of their routine to maintain their muscularity or their body image. So bring back to that question of physique competitions. What are they doing to achieve that physique, right? What are they doing to do that? And they may take the extremes of doing so. Men are very much inclined to see their primary care physician for a physical illness rather than a psychological illness. And they will not seek help for the psychological condition. So it's important that we have that communication where we show empathy, where we make them realize that what they're doing is disordered and not normal, and that we need to make sure that they are aware of this because having that conversation is so important. So it's important we show empathy, have indirect context in conversation, and be an active listener and such. So some communication techniques. Focus on feelings, not on their relationship with weight and food. Don't comment on how they look. avoid demanding that they change, avoid building guilt, and avoid providing simple solutes. So simple solutions are not the way to go, right? We need to be able to give them therapeutic communication. So the way we word things, right? Words that hurt versus words that harm. Um, these words that hurt and harm, we don't want that. We want them to help, right? So things like your body really needs fuel. Try to relax for me and take some deep breaths and try again. Food is medicine. This is your medicine. And then lastly, there are some resource tools that we can use for screening. So some tools that we can use are the Eating Disorder Assessment for Men, which includes incorporating factors that measure symptoms of male behaviors, such as muscle dysmorphia, binge disorder, or disordered eating. And then we have the two screening tools below as well. And then lastly, we have some resources. So the ANID and the NAMED are two great websites that we can use that tell you personal stories that give you eating disorders in the workplace, comorbid depression, and other medical problems associated with their eating disorders. It kind of gives them a place to note that they are normalized, that disordered eating in males are a normalized thing, and that we need to be able to address this properly. And then in the local area, we also have both the Living Hope Eating Disorder Treatment Center and the Brookway Counseling in both Bentonville and Springdale, which gives you great resource and place for patients to go seek help if they need to. And this is some great things to go to because they're both very confidential and they offer treatment from outpatient to hospitalization to inpatient, and it treats patients of almost all ages as well. So these are some great resources to give to your patient. It is so important that we do this. And lastly, do you have any questions? Thank you.